next talk is delivered by Dr. Soumitra Kumar. He is a consultant cardiologist at Fortis Hospital, Kolkata, and Chief Coordinator, Academic Services Cardiology, and he has 155 publications to his credit that speaks about his research aptitude. He is past honorary secretary of the CSI National and West Bengal branch. He is past president of Indian Academy of Echocardiography as well as past president of West Bengal Academy of Echocardiography. And Dr. Soumitra Kumar is going to talk on update on the SCORD and SOLOIST trial, cardiovascular and kidney outcome. So I am very eager to hear Dr. Soumitra Kumar on the very, very interesting topic that is with relation to sotagliflozin. Over to Dr. Kumar.
Thank you, Professor Bhadada, for the kind introduction, and thank you, the organizers, for this invitation to be part of this ADA 2021 Scientific Sessions Review on Indian Perspective. So, as you have heard, I've been asked to speak on the SOLOIST WHF and SCORED trial updates. First, I'll take up the SOLOIST WHF and then move on to the SCORED trial. And then a pooled analysis of the two, and then of course the key take-home messages. So first, talking about the SOLOIST WHF trial, this was the effect of sotagliflozin on cardiovascular events in patients with type 2 diabetes post-worsening heart failure. So the goal was to assess the safety and efficacy of sotagliflozin in reducing cardiovascular events with type 2 diabetes and recent heart failure hospitalization, and eligible patients were randomized 1:1 between sotagliflozin starting with 200 milligram per day and then moving on to 400 milligram versus placebo. And the drug was very importantly initiated just before discharge or within 3 days after discharge. So total number of enrollees were 1,222. And duration of median follow-up was 9 months, and you must all be aware that this trial was cut short because of lack of funding in view of the ongoing COVID pandemic. So the mean age was quite elderly, and 69 years, and 34% were females. Inclusion criteria was heart failure following stabilization with diuretics, and the NT-proBNP was 600 picogram per ml in sinus rhythm and more than 1800 picogram per ml if there was atrial fibrillation. And of course, the patient needed to be a type 2 diabetes. An exclusion criteria was end-stage heart failure, recent history of ACS or any recent revascularization, and EGFR, of course, had to be more than 30 because less than 30 was an exclusion criteria. And mean EGFR was about in the lower range, 35%, but mind you, as many as 21% had a EF, more than 50%. EGFR mean median was 50 ml per minute, glycated hemoglobin 7.2, and RAS blockers were received by 92%, metformin by 52%. So what were the principal findings? The trial was prematurely stopped, as I just told you. The primary endpoint of total CV death, heart failure hospitalization, and urgent visit for heart failure hospitalization for sotagliflozin versus placebo was 70 versus 98 events per 100 patient years. So this means a relative risk reduction of 33% with a very, very significant p-value. And what was even more significant, that this was achieved within 28 days of follow-up. The secondary outcomes were total CV death and hospitalization for heart failure, and again a very significant p-value and a significant event reduction. And then the first CV death and hospitalization for heart failure, again a significant p-value. CV event in isolation was not significant on the pooled intention to treat analysis, but it was significant on treatment analysis. There was an improvement in quality of life as assessed by the KCSQ score, and the changes in EGFR was not significant. The significant side effects were diarrhea, of course, genital mycotic infections, and some increased strain towards severe hypoglycemia. So overall, what was important that this was the trial which showed that it can be initiated early. The drug sotagliflozin, it leads to improvement both in HEPREF and HEPPEF patients. And we will come back to this more when the key take-home points are discussed. Now I will pass on to the SCORED trial. So this was the effect of sotagliflozin on cardiovascular and renal events in type 2 diabetes and moderate renal impairment who are at cardiovascular risk. So again, this was 1:1 randomization to sotagliflozin, starting with 200 milligram, then 400 milligram, and moving, versus placebo. And this was a much larger trial. Total number of enrollees was 10,500 plus. Duration of follow-up was also 24 months. Again, a elderly age group of population 69 years, and a higher percentage of females, 45%. Inclusion criteria, type 2 diabetes, of course, the EGFR criteria was 25 to 60 ml per minute, and patients also needed to have at least one major cardiovascular risk factor if they were aged more than 18 years, or at least two minor risk factors if they were aged more than equal to 55 years. Any planned use of SGLT2 inhibitor was an exclusion criteria. Most of the patients in SCORED had preserved ejection fraction in the range of 60%. Median EGFR was 44.4. The higher glycated hemoglobin compared to the SOLOIST trial, 8.3%. The median urinary albumin creatine ratio was 75 milligram per gram. 88% on a RAS blocker and 55% was on a metformin. So what were the principal findings? The trial was again prematurely stopped like SOLOIST, and the primary endpoint initially was major adverse cardiovascular events, namely CV death, MI, or non-fatal stroke, but it was changed to CV death, heart failure hospitalization, or urgent visit for heart failure hospitalization. So again, there was a significant 26% relative risk reduction, very significant p-value. This was achieved slightly later compared to SOLOIST, but nevertheless, it was achieved within 95 days of follow-up. And in terms of the original co-primary endpoint, again, the p-value was significant. There was a 16% relative risk reduction, and the p-value was just significant for the composite maze of CV death, heart failure, MI, and non-fatal stroke. And what was more important is that this decrease in MACE was largely because of decrease in myocardial infarction and non-fatal stroke, which has not been explicitly shown by the earlier SGLT2 trials. The secondary trials, as far as CV death in isolation is concerned, it was not significant. Neither was the change in renal parameters, probably because the study was cut short because of lack of funding. Now I will go to the pooled analysis of the two trials, which is also very significant. So overall, if you consider the two trials together, SOLOIST and the SCORED, you see the total CV death, heart failure hospitalization, and urgent heart failure visit was very, very significantly reduced when the two trial populations were put together, and this benefit was seen across all ranges of LV ejection fraction, starting from less than 40%, in the mid-range ejection fraction, that is 40 to 50%, and very surprisingly, the best benefit was in the group which had ejection fraction more than 50%. So these days we are raving about the results of Emperor Preserved, but actually the path was shown much earlier by the results of this pooled analysis of SCORED and SOLOIST in terms of benefit in HFpEF patients. So what are the key take-home messages? I will try to summarize for your benefit. So the key take-home messages that it was this sotagliflozin, which, as you know, is a unique SGLT2 because it has significant SGLT1 inhibition as well. So it was shown to be effective not only in HEP-REF patients but also in HEP-PEP patients, and irrespective of the past history of heart failure. And this substantiates not only the data of DAPA heart failure and Emperor reduced trials in HEP-REF, but was a forerunner of the Emperor preserved trials, which has been just presented with the initial top line results and is going to be presented in ESC 2021. Number 2 point, it can be started pre-discharge or shortly after discharge, within 3 days of discharge, in fact. The third point, there was significant decrease in the original co-primary endpoint of CV mortality, MI, non-fatal MI and non-fatal stroke, and this was largely driven by reduction in non-fatal MI and non-fatal stroke, which has not been explicitly shown by any SGLT2 inhibitors in the mega trials conducted with them. Number 4, by virtue of SGLT1 inhibition, sotagliflozin can lower blood glucose even in patients with CKD at least up to a eGFR of 25 ml per minute with low rates of hypoglycemia. Number 5, whether combined SGLT1 or SGLT2 inhibition has some edge over SGLT2 inhibition alone remains to be seen. We must remember that SGLT1 receptors are not only expressed in the gut but also in the late part of the proximal renal tubules, and very importantly in the heart, in the capillaries. So the initial animal studies have shown that SGLT1 inhibition can lead to less of glycogen storage in myocardial cell and less damage to reactive oxygen species. So this is an emerging area of interest whether SGLT1 inhibition can lead to greater benefits over SGLT2 inhibition alone. And the last point, unlike other SGLT2 trials, significant decrease in renal endpoints were not seen in the SCORE trial, but the point to be noted is that that again was because of the premature termination, but early eGFR changes that were seen in the sotagliflozin are similar to those that are seen with RAS blockers and with the other SGLT2 inhibitors. So sotagliflozin, I think, has shown some unique results in terms of at least cardiac protection to start with, in irrespective of past history of heart failure in both HEP-REF and HEP-PEF. It can be effective as a hypoglycemic drug. Of course, this benefit in heart failure remains for sotagliflozin limited to type 2 diabetic patients because the trial design did not include non-diabetic patients, as we have seen in DAPA heart failure and Emperor reduced and preserved. But I mean, if conducted in non-diabetic patients, we'll have to wait and see whether it extends its benefit in non-diabetic patients as well. And in diabetic patients, it can be effective as a hypoglycemic drug as well because it lowers blood glucose at least up to eGFR of 25. So with that, I conclude my presentation and I'll be happy to take part in the question answer session. Thank you very much.